All right. Thanks, y'all, for being here. We are very excited to have one of our own Emory grads, who is now an oncologist here, joining us. Dr. Ravindranathan is an oncologist here at the Winship Cancer Institute and leads the inpatient medical oncology service, where he sees patients with malignancies and manages their related medical complications. He completed his residency and fellowship training here. Despite having to work as my intern, he still stayed around. So kudos to him. And he's been fortunate to stay here at Emory for his professional career. Thank you for being here. We see your slide deck.
Okay, do you see it? Okay,
You
do you see it
you want
now?
now you're in presenter mode. Great. Okay.
Okay, so I can get started now, correct?
hmm
Okay,
Thank you.
great. Thank you, Dr. Massard, for the introduction. Yes, I was your intern, I think, a few years ago, and it's quite an honor today, this afternoon, to be presenting at Medicine Grand Rounds. So I'm going to be presenting on the topic of immunotherapy in medical oncology. It's a very broad topic, but I hope that the audience here will get something out of it and be relevant to, their respective fields. So a little bit about my journey here, kind of describing how I got started to be interested in oncology to begin with. I did my master's degree in chemistry where I did a lot of organic synthetic work and particularly making platinum-based compounds. And actually, some of the compounds we made had sort of similar structure to cisplatin, which is a therapy drug that we use widely, often here in oncology that exhibited anti-cancer activity. So we actually took that and studied, other types of cancer cells versus how cisplatin worked. And then in medical school, I actually did a little bit of research in Paneth cells, which are actually cells located at the crypts of the intestine, and looked at how they reacted once they were exposed to doxorubicin in mice models. And when I came to Emory, it's been a long time now thinking about it. In 2016, as an internal medicine resident, I was sort of open to whatever subspecialty I wanted to do. But when I started rotating through the hematology oncology clinics, I really found it gratifying to see patients with new diagnosis of malignancy at their most vulnerable points of their lives, trying to figure out a treatment plan and using the latest research, the latest treatment options to try to hopefully get them to cure or to have control of the disease to give them more time to live. And in addition to that, I had a really good inpatient exposure at Emory, whether as Grady, the VA, Emory Midtown, and University Hospital, was able to see a variety of pathologies and including patients with a new diagnosis of cancer or dealing with their complications from therapy or whatnot. And I was fortunate to work with Dr. Beelan to publish case reports in prostate cancer, as well as the Clinical Junior Urinary Cancer Journal. And then I was positioned well to go into the match for fellowship and fortunate to stay here at Emory in 2019 where I started. And it was through the time of pandemic. So it was an interesting time, as we all recall, to be trainees or to take care of patients through the pandemic. But most of my research work during fellowship was actually looking at immunotherapy response in prostate and renal cell cancer in particular. And I was able to publish over 15 publications, abstracts, present at national conferences, and rotate on the inpatient side as well through our transplant services, malignant hematology, and medical oncology services. So when I was trying to think of sort of a career option, I actually ended up enjoying the inpatient side quite a bit and, really enjoyed oncology as well. And so kind of combining both of those interests, I uh, came onto faculty here where I'm the director of the medical oncology inpatient unit at Clifton and lead the inpatient service, provide consultations for the inpatient service as well. And so, it's quite an honor again to present at Grand Rounds. I'm sure some of you on this presentation or in the Zoom call, I've worked with you either through as a trainee or, work as colleagues. So, again, really excited to be here this afternoon. A couple of photos here, when I was a medical school graduate, and then this is my last senior team when I was a resident at Grady, and then actually presented at the Clinical VNet through Division of Hospital Medicine 2017. There's a picture at my fellowship graduation. No financial disclosures, no conflicts of interest. So objectives of my talk, immunotherapy and medical oncology. First, I'll talk about how or describe how immunotherapy really works in treating, tumors. And then I want the audience to hopefully able to get how to recognize some of the effects of immunotherapy, particularly immune checkpoint inhibitors, which is the most common type of immunotherapy that we use in medical oncology. And then also review sort of how to treat some of these adverse effects that we see from immunotherapy. So outline, I'll start talking about, what immunotherapy is, the different types, how they work. And I think it's important to know how it's different from chemotherapy. And then also talk about immune checkpoint inhibitors, the history, some of the major clinical trials that led to its approval for patients, the adverse effects, how to recognize and how to manage them, and then some of my work in immunotherapy that I did primarily through fellowship. So this is a pool EV. Hopefully it works. But what comes to your mind when you think or hear of immunotherapy? It's just like an open response type of question. So if you can join by the web or join by text, you can text my name, Dravind, and message to 2233. Or if you're on a laptop or you have a QR code or something, you can log on to here. So I'll give maybe a minute or so to see if we can get some responses, and hopefully this works. Just open, just text whatever comes to your mind. I just want to kind of get what people, how think about or know about immunotherapy. Okay, I think we're seeing some responses. Hopefully we are in the audience.
We are seeing them.
Okay, perfect. Great. Oh, that was backslide, sorry. Okay, great. Great, getting a lot of responses. Yes, scared of them. Revolutionary, yes. Targeted, steroids. Great. Not chemo. That's correct. Lots of side effects. Melanoma game changer, yes. Absolutely. And actually, I'll be talking about that in this talk. Stops working at some point, that's also true. Expensive, yes. Miracle with side effects, yes. Types, yes. Yes, actually, no, actually, yes, I think maybe some people saw my presentation already because I'm going to talk about that too. Okay, you have one positive, yes. Okay, so just want to go through some of the responses. Thank you so much for your participation. Yes, ensign mAb, most of them do side effects, which we'll talk about. Pembro, which is a very common immunotherapy. Revolutionary, targeted. Scared of them? Yes, I think we should be definitely treat with some caution. Hospital complications, yes, we definitely see that. A lot of side effects, hypothyroidism, which I'll talk about. Okay, so great. Thank you so much again for your responses. I think everyone's at least aware of immunotherapy, which is good. So going on to the next slide. So yeah, so some of the responses I've heard from patients in particular are like, wait, is it like immune something, or is it like chemotherapy? Why is it so fancy? And so in order to kind of understand that, I think it's important to just take a step back and understand how the immune system works. And in this diagram, I just want to maybe start with step 7, even though it's the last step. And this is where cancer cells are being killed by the immune system. When cancer starts, at least there's a few cells of cancer. Our immune system is actually quite smart. It'll start attacking and trying to kill the cancer cells before it starts growing or into a tumor. And so when it kills, you release these antigens, and then you have, APCs or antigen presenting cells that recognize them and try to figure out a way, okay, these cells are not supposed to be in the bloodstream. And so we got to figure out a way to try to kill them. And so it goes through this process where it activates T cells, which are designed, to kill cells that are foreign. And so it's trying to traffic these T cells, eventually infiltrating into the tumors. And then this is the most important step, in that the T cells will have to try to recognize these tumor cells and to try to kill them. And so there's a way that they communicate to try to kill the tumor cells. But at some point, these tumor cells outsmart the immune cells. And that's where things can go wrong. Because when they start outsmarting, they disrupt this communication, and the tumor, the cancer cells start multiplying, proliferating, and you can have a tumor and essentially cancer forms. So immunotherapy is really focused at trying to either bypass this, what we call a stop signal, or somewhere or somehow trying to remove this stop signal. And by this way, it's going to help the immune cells to remember how to kill the cancer cells again and actively surveil, any cancer cells that may come back so that it knows how to kill it when it comes back in the future. And through this, immunotherapy can actually promise more of a what we call a durable tumor response. So, people or patients with melanoma who treat with immunotherapy, if they even have stage 4, what we call metastatic disease, disease that's spread throughout the body, with immunotherapy, they can get this treated and eventually hopefully get to a cure in even stage 4 because of how immunotherapy can work. So to further understand how immunotherapy works, I think it's important to compare with chemotherapy. Chemotherapy, just as a reminder, are cells that affect or directly attack cancer cells, either through DNA mechanism. And immunotherapy doesn't actually target cancer cells, but rather enhances the immune system. And so the side effect profile is quite different between chemotherapy and immunotherapy. Some of the adverse effects that we deal with chemo, because it also affects the healthy cells, can be hair loss, nausea, vomiting, fatigue, um, you know, drops in counts that can have patients either have neutropenic fever, anemia, or low platelets that can increase the risk for bleeding. But in immunotherapy, because it's enhancing the immune system, sometimes you can have a little bit of an overactive or overdrive of the immune system. And that could lead to inflammation in organs such as, pneumonitis in the lungs or colitis in the colon, or even like type 1 diabetes, which I'll talk about later, or hepatitis. Sometimes you can get kind of flu-like symptoms such as fever, chills, and fatigue. So overall, immunotherapy is more tolerated compared to chemotherapy, just kind of given how it's, the mechanism of action. And so again, as I mentioned before, there's potential for what we call long-term remission in patients with immunotherapy. And so another question that comes up a lot by colleagues, physicians, and even patients is, which is better? And I think this is a difficult question to answer because it really depends on the tumor type. Certain tumors like melanoma, kidney cancer, actually respond way better to immunotherapy than chemo. But testicular cancer, sarcomas respond better to chemotherapy compared to immunotherapy. For some cancers, for example, lung, the combination works well. And usually we do a combination of chemotherapy and immunotherapy first, and then kind of drop the backbone or what we call the chemo backbone and just do immunotherapy to kind of consolidate and hopefully get that, that response from chemotherapy that's rather quick, and then try to create a durable response with the immunotherapy. And in most cases, immunotherapy doesn't really work quick. And I think this comes up a lot on the inpatient side. If we have a patient that's very symptomatic from, for example, like a mediastinal tumor or something, and their cancer rather works well with immunotherapy, but we just can't really give chemo. If we can give chemo, we would, because chemo can work rather quickly to create hopefully some symptomatic relief, shrink the tumor a little bit within a couple of days or, very short amount of time. But immunotherapy can take, more than a couple of months, at least 2, 3 doses, or that can be every 3 weeks. So we're talking at least 2, 3 months before we really see a response. So the pacing and the response timing of immunotherapy is much slower compared to chemotherapy. So I think that's another distinction to note when we compare the two different types of agents. So I'm going to talk a little bit about the types of immunotherapy that are available commonly and how they're used to treat tumors. One being monoclonal antibodies. So these target specific cancer antigens. Another one, this is a little bit more of a latest type of immunotherapy called chimeric antigen receptor, or CAR T. And these actually help to genetically engineer T cells to attack tumors. And then cancer treatment vaccines, where they stimulate the immune system to try to kill the cancer. And then checkpoint inhibition, which is the most common type, which I'll spend a little bit more time on later in this talk. But these block proteins that prevent T cells from attacking the cancer. And so monoclonal antibodies, these are antibodies that are usually generated that help, we have a cancer cell here, try to block some signaling. We have something that's here that the cancer cell uses to kind of proliferate. The monoclonal antibodies can kind of block that signaling so that the cancer cell doesn't grow. Or it can also help, block any of the proteins that may be attaching to the cancer cells to help it grow as well. And some of the most common types of monoclonal antibodies that you may have been exposed to, in your careers are trastuzumab, which works on HER2, which is really common in breast cancer, as well as stomach cancer now. Not as common in breast, sorry, more common in breast compared to stomach. Rituximab, more so used in the hematology world. So lymphoma, chronic lymphocytic leukemia with CD20. And cetuximab, which is an EGFR or epidermal growth factor receptor treated with colon, head, and neck cancer. So there's different types of ways monoclonal antibodies can really work and treat the cancer. So either through direct death or through a complement-dependent cytotoxicity. So you can use complement. And this, here, just the antibody attaching to the EGFR and preventing the EGFR proteins from attaching so that it creates, direct death. Or in type C, which is an antibody-dependent cytotoxicity, or through phagocytosis. So either using like natural kill cells or macrophages. So different ways monoclonal antibodies can help treat the cancer. And another type of monoclonal antibody, this is a little bit more new, is called an antibody drug conjugate. And one FDA approved is called Enhertu or trastuzumab deruxtecan. And so this is actually a monoclonal antibody attached to a chemo. So it's kind of paired together. And this is a topoisomerase 1 inhibitor, which works on the DNA. And so the way this works is that the drug, the monoclonal antibody, gets attached to the chemotherapy, and then it attaches to the HER2 positive cancer cell to the receptor, then internalizes into the cancer cell, releases the chemo so that it can start, killing the cancer cell. So kind of a unique way of using monoclonal antibodies with chemo to attack the cancer. CAR T cell works a little differently, and this you actually get T cells from a patient, and this actually sent to a facility where they insert a gene for the CAR. And this is a commercially available, and this is mostly treated in what we call relapse or refractory. So those who have had multiple lines of therapy and the cancer is still outgrowing that. So in leukemia, lymphoma, and myeloma. And basically, you're inserting that gene so that the T cells are being re-engineered to express this CAR. And then we proliferate or grow multiple of those. And then, this is the facility comes back, and then we infuse it back into the patient to try to kill the cancer cells. Vaccines work a little differently compared to CAR T, but the process is sort of similar. So Provenge it's a cancer vaccine used to treat prostate cancer, approved in 2010. It's a busy slide, but I just want to highlight the differences in that, again, you're trying to get white blood cells or antigen presenting cells, and then you're attaching a PAP protein or a prostate cancer protein, basically, into the APCs, and then that kind of ingest and basically there's a process where this peptide will show up on the antigen presenting cells and they're primed and ready to attack cancer cells. And so then you give it back to the patient. And then when you're giving it back to the patient, you're basically activating the T cells to say, hey, go recognize anything that's, has this prostate cancer. And so then it gets activated, and then the activated T cells kills the cancer cells. So it's not really engineered to include CAR, but it kind of works in a different way, but sort of similar line of thinking. And so we talked about a couple of different types of immunotherapies, but this is the most common one. It's called checkpoint inhibition. And I want to help the audience understand two different types of proteins that are involved in this. One being CTLA4, also known as cytotoxic T lymphocyte-associated protein 4. And this is basically found in T cells. And what ends up happening is that when you have a protein called B7 on an antigen presenting cell, when this attaches to CTLA4, this actually makes it inactive. And so this is a way, sort of, as I mentioned earlier, the tumor cells can kind of outsmart the immune system. And so when it makes it inactive, the tumor cells can't really kill the tumor cell. The T cells can't attach or attack the tumor cells. And so a way that we have found is that if we block CTLA4, this communication using an antibody, we can then lead the T cell to be active and then kill the tumor. And similarly, there's other ways this also works, and this is through what we call PD-1 or programmed cell death 1 or PDL1, which is the ligand of programmed cell death. And again, the binding of PD-1 to PDL1 on the tumor cells, this actually makes the T cell response suppressed. And so if we can figure out a way, or we can block this PDL1 with anti-PDL1 or anti-PD-1, and here in this diagram shown here, then we make the T cell active to try to kill the tumor. So this is a slide to kind of summarize the different ways immunotherapy works again. So, cancer cell vaccines, which I talked about with Provenge, these are preloaded with these antigens, and so they help increase antigen presentation to T cells. But then checkpoint blockade, increases T cell activation. So that helps the T cells to kill the cancer cells. And then other ways, that the immune system can be used is, through chemotherapy, radiation to kind of induce the release of antigens and danger signals. So this is kind of a way, again, where we can use the immunotherapies to use or to enhance the immune system to kill cancer. For those who are history buffs, I'm really interested in history as well. You know, Dr. William Coley was actually the father of immunotherapy, and he was a surgeon who operated on sarcoma in the early 1900s, late 1800s, sorry, early 1900s. He saw a patient that couldn't be operated on sarcoma and that actually developed erysipelas and who has sarcoma. And with the infection, he saw that the sarcoma actually was cured. And so he felt, well, if I induce this infection in a patient, maybe I can help them cure their sarcoma. Now, this is a time where, it was pre-FDA approval, pre sort of reporting, clinical trials and all that. But he made up a cocktail called cholestoxin, where he would inject patients with strep pyogenes. And he reported, and this was actually published in New York Times, where he saw at least 150 short cures of patients who got injected with this bacteria who had sarcoma, and they were actually cured. There's been studies after that trying to replicate, and we haven't really found as great responses as he did. But I think the way he sort of thought out of box, I think was very unique, especially in the early 1900s. And so the history of checkpoint inhibition really started from 1987, where Dr. Allison identified CTLA-4, which we talked a little bit about, that downregulates T cell activation. In 92, we have Dr. Hanjo, who discovered PD-1. And then in 1996, so it almost took nearly a decade to finally have Allison's lab demonstrate that blocking CTLA-4 can really help with suppressing tumor growth, particularly in mice models. And then in 2000, that was followed up with PD-1 blockade, again in mice models as well. And before I talk about the clinical trials, there's two terms in oncology that we use quite often, and I want to make sure the audience is aware. One being progression-free survival, which is a clinical endpoint. So this refers to the time from the start of treatment until the disease progresses or the patient dies. And then overall survival refers to the time from diagnosis or start of treatment for cancer until the patient dies from really any cause. That can include cancer. And then we have different types of phases in trials and clinical trials. And one thing important to note is 1 minute here. Yeah. Okay. In phase one is that's assessing for safety and dosage. So this is a very small trial just to see if the patient can tolerate the dosage with the new drug. Phase two looks at a little bit more of the effectiveness. So can this drug really help treat, like for example, in cancer? In phase three is trying to compare, okay, we know that it works treating cancer. Can this beat what's standard of care right now? And then in phase four, you're monitoring kind of long-term safety and effectiveness after it gets FDA approved. So the first, phase three trial with ipilimumab, which is a CTLA-4 inhibitor that was approved in 2011, was sort of a game changer, particularly in melanoma. And this study looked at patients with metastatic melanoma who were already treated and basically randomized to a 3-to-1-1 fashion. So, for every 3 patients who got the CTLA-4 inhibitor plus this glycoprotein peptide vaccine compared to, IPI plus GP100 or GP100 alone. And when they treated about 680 patients, the results, looked at, overall survival, and that was about 10 months, those who actually got the immunotherapy compared to about 6 months who just got GP100, the vaccine alone. And this was quite significant back then because we really only had chemo available for melanoma, and we really had not the greatest responses. And we also looked at the median OS with just IPI alone was 10.41 months, and there was actually no difference in overall survival between the IPI arm versus GP100. And so that made the trial authors conclude that IPI with or without the vaccine actually improved overall survival. And so this led to the approval of ipilimumab for metastatic melanoma. And then in 2014, we looked at CTLA-4. Let's look at PD-1. And Nivo gained FDA approval for melanoma in the second line. And so these are actually patients who were with metastatic melanoma. This is a phase 3 trial with metastatic melanoma who had progressed with IPI, actually. So this looked at those who treated with IPI, can we use Nivo? And this looked at a 2-to-1 randomization. So 2 patients received Nivo and then 1 patient received chemo. So this is comparing kind of like a phase 3, the standard of care at the time, versus those who've been treated with IPI. And the results show that there was about 32% of those who received IPI have objective responses. So that's looking at, imaging response and shrinking of tumor, versus 10% who received chemo. And the adverse effects was about 5% in the Nivo arm compared to 9% in the chemo arm. So overall, greater proportion of patients achieving response to treatment with Nivo and fewer side effects compared to chemo. And then we try to bring up Nivo to the first line. So far, as of 2014-15, we had the immunotherapy approved in the second line or after being treated with something else. Why don't we bring it to the first line? And these results were quite revolutionary. Here is the Kaplan-Meier curve, and just to kind of review, the y-axis refers to the patient surviving, and the x-axis refers to the months, so the timeline of how long they've been living, or how long we've been following the patients for. Here you can see with Nivo, even up to 15 months or so, only about 70% of the patients are living who received Nivo or nivolumab. Whereas in the chemo arm, dacarbazine, which is a commonly used chemotherapy agent in melanoma, you can see by that time we're having almost about 20% of the patients are living. And then we also looked at progression-free survival as well. Again, a great significant difference between dacarbazine and Nivo. And so this kind of supports that there's, maybe the durable response that we're getting with immunotherapy. And then there was a trial the following year almost that looked at combining Nivo and IPI because CTLA-4 and PD-1 attack different parts of the immune system. And so if we combine it, what can we see? And we saw great responses too with this. And this is comparing Nivo plus IPI just versus IPI alone. And here's a progression-free survival. Again, we actually didn't even reach in this trial. Actually, they didn't even reach the median PFS or the median progression-free survival or the OS as well. So many patients were still, living who received the combination versus just the single agent alone. And then this actually was just recently published last year in the New England Journal of Medicine. And this looked at combining Nivo plus IPI again in a 10-year outcome. And in 10 years, in 120 months, about 42% of the patients were still, surviving who got the combination, and about 37% with single agent Nivo and 20%. So with stage 4 melanoma, this is incredible. We can see patients still living even up to 10 years. So I think someone mentioned in the poll EV that 2018, so this is the Nobel Prize that was presented to Dr. Allison and Dr. Hanjo. He's based out of Japan, Allison here in the United States, for this discovery and their work with immune checkpoint inhibition. And just kind of as a little bit of a side note, I mentioned I did my master's degree in chemistry, and my master's postdoc advisor was Dr. Negishi, who actually got a Nobel Prize in 2010 for palladium catalyzed organic synthesis. And this actually, is relevant in medicine because a lot of palladium-based, organic synthesis methods are used to synthesize a lot of the drugs that we use today. So I wanted to go through sort of the different immunotherapy agents, in particular checkpoint inhibitors that have been approved. Now, I know many of you may have seen these agents or have seen patients that have received these. So PD-L1, there's 4 right now in the market: atezolizumab, avelumab, durva, and cosimalimab. And these are approved for a variety of different tumors. The FDA approval is based on certain criteria on the tumor. So PD-L1 status, combined positive score, or tumor mutational burden. That's really more of an oncology decision, but I wanted to mention that. I'm not going to talk so much about that in this grand rounds, but that's just something to mention. And then in PD-1, we have a variety of different PD-1 inhibitors. One we've talked about, the Nivo, not just in melanoma, but in other tumor types as well. And pembrolizumab is another common one that we use in melanoma again, lung cancer, gastric cancer, and then a couple of other ones as well. And CTLA-4, there's only two in the market right now, ipilimumab in 2011, which I talked about, and then there's also one that got approved 2 years ago that's used in liver and lung cancer. One important concept in immunotherapy is to talk about microsatellite instability, and this refers to a defective DNA mismatch repair. So you can see in this diagram, there's a couple of different enzymes that help to make sure that the DNA, there's no mismatch, and if there is, they will repair it. So these are MLH1, PMS2, MSH6, and MSH2 and MSH6. And when these have, some sort of mutation or epigenetic silencing, you can get DNA mismatch. And when a tumor has like a DNA mismatch, for example, we have actually found that PD-L1 checkpoint inhibitors or immunotherapy can generate kind of new neoantigens that can be easily recognized by the immune system. And so we found that immunotherapy works even better in those with MSI tumors, those who have this mismatch repair. The hereditary cause of mismatch repair is actually known as Lynch syndrome. And with patients with this, they're a much higher risk of, for example, colon cancer, endometrial, ovarian, and require, different kind of screening guidelines. But that's just something I think is interesting to note. And actually, 2 years ago, there was a study. This is a very small sample size, but I think it was really incredible to see those who had locally advanced rectal cancer with this mismatch repair deficiency to be treated with PD-1 blockade, and they used dostarlimab here. But you can see here, two patients. This is at baseline when they got diagnosed, and they got 6 months of immunotherapy. In 3 months, the cancer was almost essentially gone radiographically and through endoscope or colonoscopy. And then here in this patient too, no evidence of cancer. So actually in this whole patients, 100% had clinical response, but no evidence of tumor, which is, I think, quite incredible, although a relatively small sample size. So in terms of immunotherapy use, I think it's here to stay. I think we're going to continue to use more and more of it. In 2011, when we just had one immunotherapy approved, at least in terms of checkpoint inhibitors, about 2% was eligible to use it. But the estimated percent of patients now, as of the list of 2018, there was about 44% of those who were diagnosed with cancer can be, eligible to use checkpoint inhibitors. And there's going to be more and more going to be administered in the future. So it's here to stay. And so I think it's important, regardless of what field you're on, to make sure that, I'm sure that we're going to be treating patients with immunotherapy or in the inpatient or the outpatient setting. So let's start with the case to kind of highlight some of the adverse effects. So we have a 65-year-old gentleman with stage 4 melanoma who started on Nivo and has received 3 cycles. So in cycle refer to each dose essentially in oncology, who presents with diarrhea, so 2 to 3 days, about 10 episodes per day. And he also had a little bit of abdominal cramping, mild nausea, but no vomiting. His vitals were relatively okay, and physical exam was notable for some mild abdominal tenderness diffusely. In terms of the diagnostic workup, we did stool studies, negative for C. diff, other infectious etiologies, slightly high white count, mildly high, elevated CRP. We ended up getting a colonoscopy that showed kind of diffuse mucosal edema, some erythema, ulcerations. Pathology was consistent with sort of lymphocytic infiltrate, some apoptosis, glandular destruction, and CT imaging also shows kind of wall thickening. And so the diagnosis with this, given that the rest of the workup was negative, relatively negative, and the fact that he had gotten immunotherapy, was immune checkpoint inhibitor-induced colitis. So in oncology, we have a way in grading adverse effects because it helps kind of reduce the subjectiveness. You can say, yes, this patient's had a lot of diarrhea, but kind of how much? And I think that helps physician to physician, particularly in the oncology world, to kind of communicate so that we know exactly how much diarrhea they've had. So we use these different types of grades using a common terminology criteria for adverse events via the U.S. National Cancer Institute. And in this, grade 1 refers to the patient being asymptomatic or mild. Grade 2 being moderate symptoms. 3 is severe symptoms, but not life-threatening. And 4 is being life-threatening. And the management depends on the grade. So in immune-related adverse effects, and we use an acronym called IRAE management, that really depends on the grade. So for example, if you have someone with asymptomatic or mild symptoms, you can just symptomatically manage it. And almost every symptom has as a grading system. So, there's a database for this. And in terms of moderate, if you have two, you can hold immunotherapy, you can start steroids, usually pred 0.5 mg per kg or something equivalent. Or in grade 3, you can again hold immunotherapy and do a higher dose of steroids. So that's either prednisone or something equivalent, or methylpred, for example. And in grade 4, if it's life-threatening, you want to permanently discontinue therapy, start them on steroids, and manage them from there. One question that comes up more for oncologists is that re-challenging. So patients who have received immunotherapy have an adverse effect that's like, for example, grade 3 to 4, re-challenging. And that can be a difficult decision because sometimes the immunotherapy was working well for them, but they can't use it. And so this is a patient, discussion, and I think it really depends on how severe the side effects were. But it can be a very challenging decision, particularly in oncology when you're thinking about re-challenging. And so there's multiple organs that are affected. And I think this is the nice thing with oncology. And another reason why I went to it is, somehow I'm dealing with an organ system differently throughout, seeing patients. So, variety of different organ systems. Here we talked about the GI system here. And so in terms of diarrhea, this is the grading systems that's been used in the CTCAE. And so grade 2 is referring to less than 4 stools per day, grade 2, 4 to 6, grade 3, 7 or more, which, pertains to this patient, or grade 4 is life-threatening. So with grade 3, we'll talk a little bit about the management, but in grade 1, if you have diarrhea, again, you want to rule out the infectious etiology, so C. diff, a GI pathogen testing. And then management really depends on the symptoms. You can consider hydration, holding immunotherapy, and consider, loperamide or Lomotil, for example. But in grade 2 to 4, you would, again, do the same sort of testing, maybe consider doing colonoscopy or CT imaging, depending on the patient's presentation, hydrate them, hold immunotherapy, and consider high-dose steroids. And usually in my practice, we do steroids for about 3 days or so. And if I'm not seeing response, then I may consider doing high dose of steroids or considering other agents, which I'll talk about later on. And so overall, like, how often do patients experience adverse effects? The trials that I had mentioned earlier with IPI and Nivo maybe talked about 10 to 15% or less. But I think as we continue to use more immunotherapy, we're definitely seeing more of that. And even in my clinical practice, I think 10 to 15% is way too low of an estimate. Based on some a systematic review that was done this year, they reported that the mean event rate for any grade IREEs was about 40%, and high grade, which refers to 3 or 4, was about 20%. And actually, monotherapy here, this table is dividing into every immunotherapy in the combination. And so you can see that, IPI, Nivo has about, IPI has about 10 to 15%, Nivo, Pembro, 5 to 14, 3 to 15, Atezo, a little bit higher at 18%. But the combination, if you're attacking CTLA-4 and PD-1, then you're creating sort of more of a robust immune response. So the side effect profile without an effects rate is going to be much higher. So we can see up to 60 to 40%. And so, combination, if you do the combination, patients are going to have a little bit of a higher chance of getting the side effects. So the next organ system I'd like to talk about is the dermatological system, so the skin. And the median onset usually average is about 4 weeks, but can range from as short as 2 and up to 150 weeks. And the range is going to differ. I'm going to talk about the range for every single side effect, but it's going to differ. And with incidence about 40%, could have different entities such as macular rash, pruritus, bullous dermatitis, lichen planus, even psoriasis. Sometimes your oral mucosa can be inflamed as well. Grade 1 or 2, you can kind of manage it with topical steroids, oral histamines if they're having itching. Grade 3 to 4, we may need to do systemic treatment and maybe even, obviously hold or interrupt their immunotherapy. And I think it's important to always involve the respective consultants, a specialist in every organ system, because I think, in collaborating with managing them, particularly, in the inpatient side, I think, it's nice to manage these patients collaboratively. In terms of nervous system, it's not as quite seen in my practice, but I do see from time to time 1 to 14%. It's a wide range again, but can be affected. And the highest, rates are seen with patients getting Nivo plus IPI with the combination immunotherapy regimen. The median onset is about 4 weeks, but can range as short as 1 and up to even 68 weeks. On average, I think, from an anecdotal evidence, I think about 12 weeks is what I see, but I've seen something as short as 1 week, but it's very rare. So if someone comes in quite just getting immunotherapy with these side effects, you really want to make sure that's really what's causing it, the immunotherapy. You want to make sure you rule out other etiologies. Some of the entities that we can see from the CNS system is myasthenia, Guillain-Barré, peripheral neuropathy, meningitis, encephalitis, some visual changes. And the management again depends on the severity because each one can have different kind of grades. And I think neurology should always get involved in these cases. And sometimes we dump steroids, IVIG, plasma exchange. In pulmonary, pneumonitis is really the main thing that we see with immunotherapy. And those treated with just single agent PD-1 or PD-L1 is about 3 to 4%, but with the combination, about 7 to 10%. The median time onset is about 34 weeks, but can range as short as 1 to 1.5 weeks and long as 130 weeks. And patients who have non-small cell lung cancer or kidney cancer or pre-existing lung disease such as COPD, emphysema, or were a smoker have a high risk of forming pneumonitis compared to those who don't. And usually patients present with like cough, shortness of breath, requiring oxygen for the first time. Always helpful to get CT imaging and then get our pulmonology colleagues involved. Sometimes radiology will call this as well. Some cases may be needed or not, and you want to make sure you rule out any other infectious etiologies. But the presentation of immune-related pneumonitis can actually differ radiographically. In this study, they looked at about 50% of the patients had ground glass opacities, but other patients had kind of a cryptogenic organizing pneumonia-like presentation, or pneumonitis not otherwise specified, or kind of a hypersensitivity-like picture or interstitial-like picture. And the management, again, depends on the grade. They're asymptomatic or mild. You can do symptomatic management, just giving them oxygen or whatnot, or treating, if they have a little bit of wheezing. But moderate, you want to hold your immunotherapy, start steroids. If they're severe, you definitely want to hold and start a, higher dose of steroids. Or if they're life-threatening, you want to permanently discontinue immunotherapy. And like kind of with colitis, once patients, for example, if they do well with steroids in 3 days with high dose, then we usually think about tapering them or transitioning to an oral form of steroids and then taper them over to 4 to 6 weeks. And then once they're done, depending on how they do, then we can talk about the next line of therapy. There's several endocrinopathies that happen with immunotherapy, and I'll talk a couple of them. One being hypothyroidism, and so every patient who gets immunotherapy who are getting started, we always get a baseline TSH and a free T4, and we check it every 4 to 6 weeks. The incidence is reported to be about 6%. And in terms of grade, if the TSH is greater than 4.5 or less than 10, we can continue immunotherapy and just monitor their TFTs. If it's grade 2, they have a little bit of symptoms, then we can continue holding immunotherapy until the symptoms resolve to baseline. In grade 3 to 4, if they have like myxedema coma or something, we definitely want to hold it, consider inpatient hospitalization. And it can happen the other way with thyrotoxicosis. Again, we keep checking thyroid function tests, but they're having asymptomatic or mild symptoms, you can consider beta blockade, if they're a little bit tachycardic. But if their TFTs continue to be, showing that they're hyperthyroidism, I think it's always helpful to get our endocrine colleagues involved if they need to treat with something else. And sometimes, we can continue holding immunotherapy until the symptoms resolve and then resume it. And if they're, in thyroid storm, you definitely want to hold and maybe, discontinue and then consider treating them. And sometimes you can re-challenge them as well. But it's a case-by-case basis. Another endocrinopathy that happens is diabetes. And so this happens, at least it's reported to be at 1% of cases. So in terms of guidelines, this is based on what we call the National Comprehensive Cancer Network, and they have these guidelines as well. And so we have a new onset fasting glucose. It's about greater than 200, or random glucose greater than 250, and they were never diagnosed with diabetes. Now, if they have diabetes and they have a random glucose of greater than 250, you want to be concerned. And then I think it's important to check their C-peptide level. And some of these patients present with DKA, so you want to try to treat the DKA, and then get endocrine involved, and based on the C-peptide levels, you may want to consider that this is maybe like a type 1 type of like diabetes caused by immunotherapy. And if their C-peptide is kind of appropriate for this serum glucose, then maybe it's just their diabetes is getting worse or something like that. And so you can continue the immunotherapy and manage accordingly. And even if they have type 1, you can still continue immunotherapy as they can be managed by insulin once they're kind of out of the DKA. And, we see these cases on inpatient from time to time. Adrenal insufficiency is something else that's also reported and also seen in clinical practice, reported about 1%. In all grades, in this case, require some type of hormone replacement and endocrine input. Primary adrenal insufficiency, it's not really that common, whereas rather, we're seeing secondary. If we're seeing primary, then it's more likely that we're dealing with hypophysitis, but I think it's always important to get ACTH and cortisol levels. And so if we are dealing with hypophysitis, we have seen these in the single agents, from 3 to even less than 1%, but 6% in the combination. But we want to make sure we get, their complete endocrine workup, whether that's their sex hormones, cortisol, ACTH, TH, free T4, serum, sodium, and then also getting a brain MRI, because some patients can be symptomatic. They can, get a little bit of swelling. So this is a neat case where it's a brain MRI when they were diagnosed with metastatic disease to make sure that the brain didn't have any mets. And then here's when they actually develop hypophysitis, you can see that the pituitary gland is quite edematous, quite swollen. And if you're concerned for mass effect, if they have vision changes or headaches or sometimes some altered mental status, you want to start them on steroids. And then we can see resolution of the pituitary gland kind of getting back to normal size. Hepatotoxicity is something we also see as well. The incidence, reported to be about 3 to 9% in CTLA-4 inhibitors, 1.5 to 5% in PD-1, 3% for PD-L1 inhibitors, and then 15 to 20% of all grades when treated with the combination. So when you're seeing someone who has elevated AST, ALT, you want to make sure you do a thorough workup. That's, making sure they don't have like hepatitis or any other issues, any other causes of hepatic dysfunction. And it's important to make sure, sometimes we have patients with liver mets. They want to make sure that the liver mets are not actually what's causing the elevated liver enzymes. And you may want to consider like elevated CK or aldolase or ferritin levels as well. Sometimes, depending on, we usually work closely with hepatology in these cases. We may want to consider liver imaging or even a biopsy. And again, the grade really dictates the management. If you have less than 3 times their upper, level of normal, you want to hold, monitor LFTs. If they're, greater than 5 to 20 times, then you want to hold and start them on steroids. And, if it's greater than 20, because, patients are high risk for really, liver failure, essentially. Nephritis is also seen, 1.5 to 5%. Again, the grade really dictates the management based on their creatinine and how, greater than is their baseline. And, nephrology can get involved. And, sometimes we may need to do prednisone in this case as well. Musculoskeletal is also seen too. And, I think it's 3 to 7% reported. I think in my practice, a little bit less, but, these side effects, can happen from time to time, and it's important to consider. You can have arthritis, inflammatory arthritis, myositis, polymyalgia rheumatica can also happen. Again, grading with the adverse effects and managed accordingly with steroids usually. Cardiac is another severe one that we've seen when it does get severe. There's an interesting sort of syndrome that we've seen where you kind of get 3 M's. So that's with myocarditis, myositis, as well as myasthenia gravis. And, the incidence is very, very, very low in the literature. And it can happen, as early as days or weeks after a couple of doses of immunotherapy. And, despite whatever cardiac, if you have abnormal tropes, you want to make sure that you do the workup regardless. So we're holding immunotherapy or getting cardiology involved. You may need to get a cardiac MRI or cath, et cetera, and try to treat them accordingly. So, steroids work well for the most part, but there's always cases where steroids may not work. And we call this more of a steroid-resistant IRAE kind of entity. And we define this as a lack of improvement 48 to 72 hours. I should wait at least 3 days, sometimes a little bit longer, depending on the patient case. But, because these side effects are relatively rare, compared to other side effects, there's not as much literature in this, but, there are some reports that, about 23 to 50% of hepatitis require additional cases of additional, immunosuppression if they don't respond to steroids. One third to two-thirds with colitis don't respond to IV steroids initially, or about 20% don't respond to steroids in pneumonitis. And there's limited evidence that I could find on myocarditis. And so when we do have a situation where steroids don't really work, there are other agents that we use. And here's a diagram that's showing, with hepatitis, we sometimes use Salcept or mycophenolate mofetil, or in colitis, we sometimes use infliximab or vedolizumab. And in pneumonitis, we also use mycophenolate as well, or Salcept. And in myocarditis, we have sometimes used abatacept, ruxolitinib, or anti-thymocyte globulin. And these work in different ways, trying to trigger the immune system in different avenues. So abatacept kind of blocks the interaction of CD80, 86 on antigen-presenting cells with CD28 on T cells. And then vedolizumab kind of works on this protein on the mucosal surface called alpha-4 beta-7. Ruxolitinib is actually used on JAK1, JAK2, also used in hematological syndromes such as myelofibrosis, interestingly. And then infliximab binds to TNF alpha, and mycophenolate kind of works in the purine biosynthesis pathway to basically inhibit more purine synthesis that actually has immunosuppressive effects. So now we've talked a lot about sort of recognizing different adverse effects from immunotherapy, and I want to talk a little bit about a concept that we see in immunotherapy called pseudoprogression. And this is where the tumor may appear like it's actually progressing or growing, despite getting treatment, but it's actually not. And this is caused by, in this diagram, because you have more infiltrates of lymphocytes and macrophages kind of going towards the tumor to try to hopefully attack and kill the cancer cells. But in imaging, this is hard to differentiate. And so this is a nice case where someone with liver cancer, using their alpha-fetoprotein, that's a tumor marker that's heavily elevated in liver cancer, for example, or hepatocellular cancer. This is someone who just got, at baseline with 16.2, and they got immunotherapy. In 3 months, we did restaging scans, and you could see that some of the liver spots are much bigger. And, it's definitely concerning them. Are they progressing? Are they not responding? And their AFP is even higher. But you continue them, and actually in a month, you can see that these liver spots are much smaller. So this is something to keep in mind. And so sometimes, patients get admitted who are getting immunotherapy, and they have scans or whatnot for some symptom they presented, and the scans will say, progression of disease, worsening disease. And so this is something important to keep in mind if these patients, obviously it's the final oncologist call, but this is just an interesting concept to keep in mind. So I want just to finish off my grand rounds talk by talking about some of the work that I had done with immunotherapy. So I looked at a marker called neutrophil to lymphocyte ratio. And this has actually been known to measure kind of systemic inflammation in several tumors. And, one thing that we don't really know with immunotherapy is that, yes, sometimes PD-L1 status, things like that can predict, but we don't have like a good biomarker, like something that we can use in the blood work to really say, yes, they're going to respond to immunotherapy. I know I didn't talk much about targeted therapy, but if someone had this target, we know it's going to work well. But in immunotherapy, we don't really have like biomarkers to guide us. And so we wanted to use this study to see, can we use like a neutrophil to lymphocyte ratio that we can just get off a CBC to see if that can help as a predictive marker for patients with metastatic kidney cancer receiving immunotherapy. This was a very small retrospective study that we did with patients treated at Winship. And, two things like neutrophilia and lymphopenia are associated with poor prognosis. And one thought is that, we know that the immune system is using lymphocytes primarily with T cells. So we have more lymphocytes. Does that mean that patients respond better to immunotherapy if they have higher lymphocytes at baseline? So through analysis, we were actually able to figure out that at a cutoff at the neutrophil lymphocyte ratio at 5.5. So if you have more neutrophils, more neutrophils and less lymphocytes, that means you're going to have a higher ratio. And then more lymphocytes and less neutrophils, you're going to have a lower ratio. So if you have more neutrophils, less neutrophils, usually means, yes, less systemic inflammation. So they're going to be hopefully doing better. And that's what we found, is that the pre-treatment N to LR, or neutrophil to lymphocyte ratio, the less than 5.5 was associated with the superior progression-free survival and overall survival. And then we actually looked at a different ratio called neutrophil to eosinophil ratio. And eosinophils have been known to help with recruitment of T cells and immune system. There's actually been some studies studying with melanoma, and they found that there's a potential role for baseline eosinophil count to be a predictive biomarker to see if they respond better to immunotherapy. And so we took, this sort of basis to say, let's see in kidney cancer if this is something that we can see, neutrophil eosinophil ratio or NER. And we did a retrospective study about 180 patients. We found, through analysis to have a cutoff about 49.2, that the high group, so this again having more neutrophils, less eosinophils, but low group would be more eosinophils and less neutrophils, and that decreased OS was associated with the elevated NER. But there was actually no difference in progression-free survival. And so you can see in these Kaplan-Meier curves, with OS, there's a little bit of a difference in overall survival, but the PFS, these survivals are almost neck to neck. And so if you have a low NTR at baseline, maybe you're going to do better with the immunotherapy, sort of what we got out of this small retrospective study. And that elevated baseline NER may be associated with shorter OS with stage 4 renal cell cancer treated with immunotherapy. So I want to finish off my talk with acknowledging, thank you to Dr. Massar and Dr. Akhbashev as well to get me this invitation. So again, an honor to present to Grand Rounds today. Dr. Beelan, who has been very helpful with my research work that I have done, Department of Medicine and Emory as well, and the Winship Cancer Institute. And now I'd like to open up the floor to any questions. And thank you so much for your attention.
Thank you, Deepak, for that excellent talk and really informative review of a lot of core material. What questions do we have in our audience? Yes, Carrie?
Thanks, Deepak. That was a great presentation. I just wanted to ask, I know that you suggested using steroids when people present with toxicities from the immunotherapy, but I've always wondered about when patients need steroids for other indications unrelated to these toxicities, how it might interfere with their immunotherapy responses and kind of walking that delicate balance. I always consult the oncologist, but I'm wondering if there's some general guidelines.
Yeah, that's a really good question. When someone is on steroids for other indications other than, they're treating their, we really try to avoid using immunotherapy. Something happened.
Deepak, are you there?
Yes.
Okay.
Hello, can you hear me?
Yep.
Yes. Yep.
Okay, sorry, it like froze somehow. Okay, can you hear me now? Okay, good. Okay. So if I think a general guideline is if someone's on like 10 milligrams or less.
Oof.
Okay, sorry, I'm back.
Okay.
Okay, sorry. Okay,
The last thing we heard was if someone's on 10 milligrams or less, dot, dot, dot.
yes, okay. If someone is less than 10 grams or less, I think we could use immunotherapy kind of concurrently. But if you can get down to them, because sometimes we have, patients with steroids for some indication. So if they're on prednisone, like oral 10, I think I'm more comfortable using immunotherapy, but it's a really case-by-case basis. Hopefully that is helpful to know. If they're higher doses, we really try to get them down because immunotherapy and getting steroids concurrently is not a good combination. It really decreases their effectiveness. I think there's
couple questions in the chat. Any research going on with prostate cancer on immunotherapy?
yes. Right now, so pembrolizumab was approved for prostate cancer if they have what's called a tumor mutational burden. That's like 10 mutations greater, and so it's a very small subset, like maybe 2%. Right now, there is a clinical trials using what's called BiTE therapy. I didn't talk about that so much in the talk, but it's basically trying to link two different types of antibodies to try to attack prostate cancer cells. one thing about prostate cancer, why immunotherapy hasn't been so much on the forefront, although cancer vaccine has with Provenge, but like, for example, CTLA4 or PD-1, is because there's thought that prostate cancer is kind of cold and it's kind of inert, and it's really hard to kind of, attack. And so that's where immunotherapy hasn't been quite successful. It's one of the kind of proposed theories. But yes, there's a BiTE therapy ongoing right now. It's a clinical trial for prostate cancer. We actually have a phase 1 trial here at Emory.
Next question. Can you please comment on cases of hyperprogression with immunotherapy?
Yes, I haven't had as many cases of hyperprogression. I think it happens from time to time. I guess, do they mean like they're actually progressed quickly from immunotherapy? Is that what they're meaning by hyperprogression? I want to make sure I clarify what they mean by that. I don't know if they're able to chat. Yes, advancing. Okay. Um, yes, so there is going to be I know I didn't talk so much about response rates, but there's always going to be a subset of population that will not respond. And these patients can hyperprogress. So their disease just kind of really just progresses and just blows up despite getting 1 or 2 immunotherapy. Yes, I have seen a lot of cases, and it's really difficult with those cases because you really only have immunotherapy after that, or if you thankfully have a mutation. But those patients really don't end up responding too well if they progress to immunotherapy rather quickly. We do have cases of that, although not as common, but there are. I think the next question I can read off, is there a risk of incidence of side effects different with someone having underlying autoimmune disease? It's a really good question. I don't know if we've had like like retrospective studies to say that, but a lot of the times, if someone has an autoimmune disease or transplant, we try to be very careful in treating them with immunotherapy. Usually, we have to work and talk to their rheumatologist. Now, if they're quite like have a quiescent kind of room issue, or they're in a very low minimal dose of steroids, we do sometimes challenge them with immunotherapy. But the risk of side effects, it's probably going to be a little bit higher because their immune system is already suppressed. From my anecdotal evidence, I have seen that patients with rheumatological issues have a little bit of higher incidence of immune-related adverse effects. How do you decide when to start chemo versus old-fashioned immunotherapy? Any indicators to consider who will be high risk for immunotherapy-related side effects? Great question. I think deciding to start chemo versus immunotherapy really depends on the tumor type. If someone's presenting with melanoma, never doing chemo upfront. For example, if someone has lung cancer, it depends on their what we call PD-L1 status and other markers. But sometimes, for example, if they're in the hospital, they just have a lot of tumor burden. We sometimes can start with chemo and then use immunotherapy later on. So I think the decision really depends on the tumor type, but also the presentation. If they have a huge burden of a disease, and chemo and immunotherapy together will be a good combination, it really depends on the tumor type. And then let's see, many moons ago, we tried interferon for similar immune stimulation. Yes, we did. Do you see new checkpoint as the new generation? Checkpoint as the new generation Ds? Yes, I think so. Interferon was terrible in terms of even response rate. It was used in kidney cancer and melanoma before 2010. And I think this is sort of the new generation. I really do. There is some role for interferon still, like, if someone has progressed to immunotherapy, and for example, in kidney cancer or melanoma, and chemo just doesn't work well, as I've shown in the slides. Yes, if if they can tolerate, we have used interferon in those settings, although we really try to avoid that. But I think immune checkpoint inhibitors are going to be really the way to go as of now for more and more years to come with, many tumor types.
All right. Again, thanks everyone for being here. Thank you to Deepak for this incredible session. And to claim your CME code, please do complete an evaluation today. And just remember that when you are submitting your code, don't use the word attend with the code. It is instead CERTIF based on new CME office policy. All right. Thanks, y'all. Have a great afternoon.
Thank you.